Hi, in this presentation, my group members and I will explain in details about psychiatric disorder associated with hearing loss, then mechanism linking hearing loss to psychiatric disorder. We will also further explain about psychiatric screening and audiological screening for patients with hearing loss, and discuss about management strategies for psychiatric disorders in patients with hearing loss. And lastly, we will show some case study as example of psychiatric patient with hearing loss.
Psychiatric comorbidities are increasingly recognized as significant consequence of hearing loss. Beyond communication difficulties, hearing impairment disrupt emotional, cognitive, and social functioning, leading to higher rates of mental health disorder. In this section, I will briefly outline the major psychiatric conditions associated with hearing loss and their underlying mechanism. Depression is a common psychiatric condition in individuals with hearing loss, presenting with persistent sadness, loss of interest, irritability, and reduced motivation. Communication barriers often trigger social withdrawal, which increase emotional distress and contributes to the development of depressive symptoms. Subtypes such as major depressive disorder and dysthymia may occur, and prevalence rates are notably higher than in the general population. Depression also has functional implications, as affected individuals are less likely to engage consistently with hearing rehabilitation, leading to poorer communication outcomes. Recognizing depressive symptoms early is essential, as timely treatment can improve both psychological well-being and the effectiveness of audiological interventions. Anxiety disorders, including generalized anxiety, social anxiety, and panic disorder, are significantly more prevalent in people with hearing impairment. These disorders arise from the continuous effort required to interpret speech and the fear of miscommunication, which heightens stress and leads to avoidance of social situations. Over time, reduced social interactions limit auditory and cognitive stimulation, reinforcing anxiety symptoms. Clinically, individuals may experience restlessness, excessive worry, and difficulty sleeping. Anxiety can interfere with hearing aid use, therapy participation, and overall communication confidence. In children, anxiety may also manifest as academic avoidance. Early screening is important to prevent a cycle of withdrawal and declining communication functioning. Hearing loss is strongly associated with cognitive decline, including mild cognitive impairment and dementia. Cognitive symptoms such as forgetfulness, reduced attention, and slow information processing may emerge. The cognition load hypothesis explains that the brain must allocate extra effort to decode unclear sounds, leaving fewer resources for memory and reasoning. Additionally, social withdrawal caused by communication difficulties reduce cognitive stimulation, further accelerating decline. These changes can worsen communication outcomes and increase emotional burden. Early recognition of cognitive symptoms is essential, as combined audiological and cognitive support can help maintain functioning and reduce long-term impact. In some individuals with profound or sudden hearing loss, auditory misperception or hallucination-like experience may occur. These symptoms are often related to sensory deprivation, in which the brain generates internal auditory signals in the absence of adequate external input. Patients may report phantom sounds, unclear voices, or increased suspiciousness. Although these experiences are generally not indicative of primary psychotic disorders, they can be distressing and may lead to withdrawal from social or rehabilitation activities. Awareness of this phenomenon is important so clinicians can differentiate sensory-driven misperceptions from true psychosis and provide appropriate support. Some individuals with hearing loss develop substance use disorders, including alcohol or drug misuse, often as maladaptive coping strategies for stress, frustration, or co-occurring mood symptoms. Although less common than depression or anxiety, substance misuse can significantly impair functioning, decision-making, and participation in hearing rehabilitation. Dependence may worsen cognitive performance, emotional stability, and social relationship. Observational evidence suggests increased rates of substance misuse among adults with long-term hearing impairment, emphasizing the need for routine screening. Addressing substance use is critical to ensure effective rehabilitation and overall mental health. Children and adolescents with hearing loss are at higher risk for behavioral and emotional disorders, including ADHD-like symptoms, oppositional behavior, and mood dysregulation. These issues often arise from delayed language development and difficulty communication needs, leading to frustration and challenge in social interaction. Consequences include academic difficulties, strained peer relationship, and reduced self-esteem. Early hearing interventions such as hearing aids, cochlear implants, and speech therapy plays a major role in reducing this risk. Identifying behavioral concerns early allows for appropriate school and psychological support, improving overall developmental and emotional outcomes.
Now, we look at the mechanisms that link hearing loss to psychiatric disorders. The first one is social mechanism. Hearing loss is strongly associated with social isolation and loneliness. People with hearing loss often withdraw from social activities due to difficulty in communication because they struggle to follow conversations in noisy environments and feel embarrassed when they have to ask others to repeat themselves. This constant worry about miscommunication and the fear of being judged makes them avoid social situations. As a result, they experience social isolation and loneliness. When social interaction decreases, the risk of dementia, cognitive decline, depression, and anxiety also increase. This is because fewer interactions mean less stimulation for the brain. So research shows that social isolation is a major risk factor for poor cognitive performance and faster cognitive decline. Previously, I mentioned that when someone experiences hearing loss, they become socially isolated. This can fasten cognitive decline and increase the risk of dementia. This happens because the brain experiences cognitive loss, auditory deprivation, and eventually leads to brain atrophy in certain brain regions. Besides, reducing social interaction can lower the auditory input received by the brain. So when the brain receives less stimulation, the neural activation in several brain regions is reduced and leads to brain atrophy in brain areas that are responsible for hearing and higher cognitive functions like temporal lobe, frontal cortex, auditory cortex, and hippocampus. Hearing loss puts additional cognitive stress on the brain by requiring it to work harder to interpret distorted sounds and reduce its ability to perform other tasks. Therefore, fewer cognitive resources are available for other tasks like memory, attention, or problem solving. The cognitive load hypothesis suggests that when hearing loss occurs, the brain receives poorer auditory signals. So the brain has to use more cognitive resources for auditory processing and decrease the resources for other cognitive tasks. This diversion of resources leads to cognitive fatigue, reduce the cognitive reserve, and cause cognitive decline. So the diagram shows how healthy individuals can allocate the resources normally, but hearing impaired individuals must shift more resources toward listening. This accelerates neurodegeneration and leads to brain atrophy. The last one is psychological mechanism. People with hearing loss often experience increasing anxiety as their hearing worsens. For example, they worry about miscommunication or being judged in social situations. They also may have anxious thoughts like, will I lose my job if I cannot follow a critical conversation at work? Or what if I cannot hear my phone and I miss an important call? So we know that there are several types of anxiety disorders like specific phobias or obsessive compulsive disorders. So patients develop specific phobia around situations that they expect would be difficult to hear, like at the social gathering. In the case of OCD, they have the tendency to repeatedly check and change their hearing aid batteries due to the fear of the device dying. Overall, anxiety disorders are more common in people with hearing loss than in the general population, mainly because of fears related to embarrassment or misunderstanding. And this is particularly common among those with moderate to severe hearing loss. Now we move to the depression part. Social isolation plays an important role in the development of depressive symptoms. Hearing loss causes people to withdraw from social interaction because communication can become tiring or embarrassing. Yet it also can lower a person's self-esteem because they might feel less confident during social interaction. This situation increase the chance of feeling lonely and isolated, which contributes to depression. As I explained before, people with hearing loss need to work extra hard to follow conversation. This constant effort can lead to fatigue and social withdrawal, making them feel even more alone. Besides, it also increase the cognitive load. This extra strain can affect the brain areas that regulate emotion, like prefrontal cortex and amygdala. This can influence the brain chemistry and structure and contribute to depression. Studies also show that the more severe the hearing loss, the higher the level of depressive symptoms. People with hearing loss tend to experience more depression compared to other degree of hearing loss.
Psychiatric symptoms in people with hearing loss are often missed because of the communication barriers. This makes it difficult for clinicians to accurately understand the patient's emotional state. Because of that, early screening is very important. It helps us detect depression, anxiety, cognitive decline, and social withdrawal before this problem becomes worse. Accurate screening also leads to better treatment planning, better rehabilitation outcomes, and improved patient safety. Since these patients require more support, collaboration between audiologists, mental health professionals, and family members is really important. Some screening tools commonly used include patient health questionnaire for depression, generalized anxiety disorder for anxiety, hospital anxiety and depression scale for anxiety and depression, and also geriatric depression scale specifically for older adults. The psychiatric assessment usually begins with the clinical interview. Most information comes from this first conversation. So the mental status examination, or MSE, is used to evaluate the person's general functioning. So during this exam, the clinician looks at 5 key areas, which is general appearances, speech, emotional expression, thinking and perception, and also cognitive functions. This observation helps identify any sign of psychological distress or cognitive challenges. Next is personal inventories, which is questionnaire meant to assess people's typical way of thinking, feeling, and behaving. The most commonly used is multifaceted personality inventory, MMPI. MMPI present respondents with sentences describing moral and social attitudes, behavior, but psychological states and physical conditions. Patients need to state whether the statements are true or false. Some examples of statements is I would rather win than lose in a game, or people often disappoint me. Despite the importance of screening, there are several barriers that we need to keep in mind as we are dealing with patients that have hearing loss. So first, communication gaps can cause incomplete and inaccurate responses. So some patients may underreport symptoms due to shame or fear of being misunderstood. Clinicians may also misinterpret behaviors related to hearing loss. For example, slow responses may be mistaken for apathy. Standard screening tools are not always deaf-friendly, which can affect accuracy. And finally, there are not many mental health professionals trained in deaf culture, which further limits proper assessment. So now we take a look at the audiological assessment. This involves gathering information about a person's hearing condition because hearing loss is closely related to psychiatric risk. So this assessment includes built-in audiometry, tympanometry, speech audiometry, and also auditory brain response. First, we assess our patient by conducting built-in audiometry test. Built-in audiometry test is a test that measures the softest sound a person can hear at different frequency. This test is important in measuring the degree and the type of hearing loss based on the patient's threshold. So there is 3 types of hearing loss, which is conductive, sensory neural, and also mixed hearing loss. Next, we will conduct speech audiometry for further testing. Speech audiometry measures how well a person can detect and understand spoken words. So these tests show how hearing loss can affect daily communication. Third is tympanometry test, where audiologists will measure the middle ear function and also the mobility of eardrum across pressure changes. Consequently, abnormalities in this test will significantly provide a result of conductive or mixed hearing loss in a patient. Lastly, auditory brain response test measures the electrical signals from auditory nerves to the brainstem. This test is very useful for the patients that cannot respond reliably. For example, patients with disabilities and also uncooperative adults. This test also frequently used in newborn hearing screening.
Assalamualaikum and happy good day to everyone. My name is KHAIRINA Binti AZIZUL. So I will continue for the next part. I will present about management strategy for psychiatric disorder in patients with hearing loss. Individuals with hearing loss are actually at a much higher risk of develop various psychiatric disorder. These include depression, anxiety, social withdrawal, and even cognitive decline. Research show that this psychological challenge often occur because hearing loss create communication barrier, increased listening effort, and leads to social isolation and reduced access to auditory information. There is support by studies who found strong association between hearing loss and poor mental health outcomes. Because of this risk, effective management strategies are extremely important. Good management can help improve emotional well-being, strengthen communication abilities, reduce psychological burden, and support better daily functioning. According to World Health Organization, early and ongoing intervention is crucial because untreated hearing loss can worsen psychiatric symptoms and contribute to long-term mental health problems. So, management should ideally begin as soon as we see signs of psychological distress. such as anxiety, irritability, or withdrawal, or when communication difficulties start to interfere with daily life. It should also start when hearing loss itself begin affecting a patient's emotional or mental well-being. First, audiological management is one of the most important strategy for addressing psychiatric disorder in individuals with hearing loss. The main goal in this area is to optimize the person's hearing using devices such as hearing aid, cochlear implant, or other assistive listening technologies. So when we improve hearing access, we actually reduce the communication difficulties that are strongly linked to emotional and psychological problems. They show that difficulties in communication are directly associated with higher level of anxiety, depression, and emotional strain. So by improved hearing loss, we reduce the emotional burden. So there is strong evidence support the benefits of amplification. Ferguson found that hearing aids significantly improve quality of life, increase social engagement, and enhance overall emotional well-being. This means that better hearing does not only help with communication, it also improves our mental health. So for individuals with severe to profound hearing loss, cochlear implant is also highly effective. They report that cochlear implants are associated with improved mood, reduced psychological burden, and better social functioning. So even in most severe cases, restored auditory access has clear mental health benefits. Another important part of audiological management is regular follow-up appointment and device fine-tuning. Consistent follow-up help prevent decline in hearing clarity, which can otherwise worsen psychological symptoms or increase frustration. According to AIREEN, effective monitoring ensures stable communication access and reduce anxiety that may arise from inconsistent hearing performance. Overall, audiological management is essential because improving hearing directly support emotional stability, social functioning, and mental well-being. Next, psychological and psychiatric intervention play a crucial role in managing mental health difficulties among individuals with hearing loss. One of the most effective therapeutic approach is cognitive behavioral therapy, or we call as CBT. According to the American Psychiatric Association, CBT is highly effective for treating depression and anxiety because it helps individuals identify and restructure negative thought. These negative thoughts often arise from communication challenge, social fear, or past experience of misunderstanding due to hearing loss. By reframing this thought pattern, patients gain better emotional control and reduce psychological distress. However, because individuals with hearing loss rely heavily on visual information, CBT needs to be adapted to ensure full understanding. The World Health Organization recommended that adapted CBT should include visual support such as writing prompt, diagram, gesture, and clear visual cues. These adaptations are essential because they allow patients to follow the therapy process more effectively if lost due to communication limitation. Another important component of psychological management is supportive psychotherapy and counseling. Counseling play a major role in helping individuals with hearing loss handle the emotional challenge they face on a daily basis. Through counseling, patients receive emotional validation, which means their feeling of frustration, embarrassment, or isolation are acknowledged and understood. This support is crucial because many individuals with hearing loss struggle with issues related to stigma, frequent communication breakdown, and reduced self-esteem. Counseling also teach practical coping strategies that help them manage stress more effectively and navigate difficult social situations. So research also support the effectiveness of counseling as well. They found that individuals with hearing loss show better emotional adjustment when they have access to structured counseling or psychological support. So this means that counseling not only improve day-to-day coping but also strengthen long-term emotional resilience. One of the key communication strategy in manage psychiatric difficulty among individuals with hearing loss involve making simple but effective environmental modification. So improve lighting, reduce background noise, and positioning speaker directly face-to-face can greatly reduce listening effort. When the visual environment is clear and distractions are minimized, individuals with hearing loss can rely more effectively on speech reading and visual cues. According to the World Health Organization, this modification significantly reduce stress level during communication because the person does not have to work as hard to understand speech. So this strategy also have a direct impact on emotional well-being. When communication becomes easier, individuals feel more comfortable engaged in conversation, which reduce anxiety and increase their confidence in social situations. As a result, they are more likely to interact with others, participate socially, and experience fewer feelings of isolation. Next, another essential communication strategy is family and caregiver communication training, because hearing loss affects not only the individual but also the people around them. Educating family members is a key part of improving emotional and social outcome. Family members are taught to speak clearly, maintain eye contact, use appropriate gesture, and confirm understanding during conversation. This small adjustment help to reduce communication breakdown, strengthen relationship, and minimize emotional strain. When communication becomes smoother, the individual with hearing loss feel more supported, less frustrated, and more confident to interact with others. So, family involvement is also a strong protective factor in mental health. According to the World Health Organization, active participation from family members have reduced psychiatric symptoms such as anxiety, depression, and social withdrawal among individuals with hearing loss. So, supportive and well-informed caregiver play an important role in creating a positive emotional environment.
Now, let's look at the first case study. This case involved a 36-year-old male construction worker who developed adult onset, moderate to severe bilateral sensorineural hearing loss. After losing his hearing, he began showing persistent depressive symptoms, irritability, and gradually withdrew from social interactions. Because of this change, he referred for psychological intervention. Clinically, he was provisionally diagnosed with the adjustment disorder with depressed mode based on the DSM-5. His audiology results and anti-finding show that the hearing loss contributes significantly to his emotional distress. Like many adults who acquire hearing loss later in life, he experienced a grief like reaction, struggle with identity, reduced autonomy, and difficulty maintaining communication with others. The therapeutic plan for this patient includes several accessibility-focused adjustments. Session use written prompts and visual aids. The therapist slowed down the speech and used more gestures and create a quiet, distraction-free environment. At times, his spouse helped support communication. The treatment followed a phase-based intervention model. The first phase is phase 1, which is engagement and support. The goal was to build a rapport and provide emotional support while validating his struggle. And phase 2 is cognitive restriction and behavioral activation. Using cognitive behavioral therapy technique, it challenged the negative thoughts such as I am useless now. Behavioral activation encouraged him to slowly re-engage in meaningful activities. And phase 3 is coping skill consolidation and family involvement. Here, coping strategies were strengthened and his family was included to support consistent communication and emotional adjustment. The second case study is about an 18-year-old boy diagnosed with autism spectrum disorder, ADHD, and hearing loss. Research shows that the percentage of children with ADHD who also have hearing loss is greater than the percentage of ADHD in normal hearing children, and a high number of children with severe hearing loss were also diagnosed with autism compared to those who with less severe hearing loss. Although this boy has normal cognitive skill, he displays several behavioral and emotional challenges. This includes repetitive speech, social anxiety, irritability, isolation, insomnia, and even self-harming behaviors like hitting walls. His repetitive talking and reluctance to engage appear to be coping strategies used to manage discomfort and challenging sensory and social situations. Overall, his behaviors align with both SSD and ADHD, and these conditions are further complicated by the presence of hearing loss. The lack of clear auditory inputs affects his ability to communicate, regulate emotions, and interact socially. This combination increases frustration and heightens sensory sensitivity, making day-to-day functioning more difficult. In conclusion, hearing problems are often linked to psychological disorders and can have a major impact on emotional and social well-being. They can lead to depression, anxiety, cognitive change, and social withdrawal because of ongoing communication barriers. Our case studies clearly show this. One adult developed depressive symptoms and isolations after experiencing hearing loss, while an adolescent with hearing impairment experienced behavioral, emotional, and neurodevelopmental challenge made worse by communication difficulties. These examples highlight why early screening is important, since psychiatric symptoms in individuals with hearing loss can be overlooked or misunderstood. The most effective managements use a combination of hearing supports, counseling, and clear communication strategies. With early detections, proper treatment, and family involvement, individuals with hearing loss have a better chance of maintaining emotional well-being, improving daily functioning, and enjoying a high quality of life.